Thank you so much. Proverbs, let me put this in my pocket. Proverbs 18:17 says that he who speaks first sounds right until his neighbor comes and questions him. So I want to thank the NCBC and the Pellegrino Center and the Center for the Law and the Human Person for inviting me to pull back the curtain and show you the other side of the story. Also, I'm going to be taking some pot shots at my good friend, Dr. Krista Koch. And so I want you to know we are the best of friends. We flew out together. We went shopping together. We saw the museums together. We had dinner together. And as iron sharpens iron, so one man sharpens another. And so we make each other better by having this dialogue. And so, I appreciate that he is able to have this good relationship with me, and we can go forward for our patients making things better. All right, so let me find out where the tech is. Let me move. Am I talking into this one?
Yeah.
Okay, I gotcha. So I had a personal experience with this, so let me tell you. In the first year of my anesthesiology residency program, I came in for night call, and they said, Klessig, glad you're here. Go up to ICU. We've got a brain dead man that we're going to have you bring down for organ harvesting. And I'm thinking, I think I heard a lecture on brain death in medical school, but it's been a while. So, I didn't want to look stupid. So I said, gosh, brain death, huh? Is there anything different I need to know? And the doctor looked at me and he kind of laughed and rolled his eyes. He goes, just be sure someone has declared him brain dead. You know how eager the transplant team is? So up I went. And I found a young man. He was about my age. He had been in a motorcycle accident and had a severe traumatic head injury. And yes, the neurologist had declared him to be brain dead. But when I went to look at my patient, he looked, like the picture here. He had normal vital signs. He had excellent oxygen saturation. His skin was warm and supple. I mean, he looked like every other ICU patient I'd anesthetized, and in a lot of ways better than a lot of them I'd done. So I went back down to the operating room and I found the anesthesiologist who was going to supervise me. And I presented the patient and he said, okay, what's your anesthetic plan of care? So I said, well, I think I'm going to use a paralyzing agent because, surgeons get kind of cranky when people are moving and they're trying to operate. And I'm going to use fentanyl, a potent painkiller, to blunt any heart rate or blood pressure responses that might damage the organs. Well, then he looked at me and asked me, are you going to give a drug to block consciousness? And I was stunned. I said, why would I do that? Isn't he dead? And he just looked at me. He gave me this long look over his mask and he said, why don't you give one just in case? Well, I'll tell you, I did as I was told, and the young man responded to surgery just like anybody else, requiring the same types and amounts of anesthesia. And when I told the story to a pathologist friend, she says when she removes organs in the morgue during an autopsy, she doesn't have to give any of these drugs. So it is my regret over having participated in a case that my gut was telling me I was wrong that motivates me to be speaking here today. My conscience was nagging me, but I listened to my authorities. And if you listen to the arguments for brain death, you'll hear it again and again, arguments from authority, arguments from the majority. There's very little data on this. So it made me think, when is someone dead? If you can be resuscitated, you were never dead. No one comes back from the dead, which would be resurrection, without divine intervention. But, most people I talk to, there's very few pure materialists out there that think we're just meat in motion. I mean, most people think that death is, as the other speakers have mentioned, the separation of the spirit, soul, the life principle. But of course, the spirit being immaterial, we don't have a device to sense that exact moment. So historically, what we've done is declare death when there's the complete cessation of all functions of the entire body beyond all possibility of return. And we looked at the evidence and we talked about differences between the philosophy and the evidence. The evidence is has been the absence of heartbeat and breathing. But this definition changed, and here's the landmark article from JAMA, a definition of irreversible coma. 13 men at Harvard Medical School proposed redefining death meaning people who were in a coma that up till then had always been considered to be alive could now be somehow dead. They had no tests, they had no studies, they had no evidence for that. They said our primary purpose is to define irreversible coma as a new criterion for death. And the only rationale they gave was utility. They said these people are a burden to themselves and to others. And this redefinition will free up beds in intensive care units, and it will facilitate organ donation. And of course, this definition certainly was of great utility because it allowed organ procurement to skirt the dead donor rule by simply, by the stroke of a pen, by fiat, declaring people in a coma to be, certain people in a coma to be dead. And Chris brought up the collaborative study. And this study was done when the prevailing criteria in this country were the Harvard criteria, which are stricter than the AAN criteria that we use now. In addition to what the AAN guideline suggests, the Harvard criteria also required 2 flatline EEGs, absent spinal reflexes, and complete immobility. And you saw the respirator brain from Dr. Aksamet. They looked at the autopsies, and of 226 brains autopsies, 10 were grossly normal, and only 40% showed respirator brain or total brain infarction. The investigator said it was not possible to verify that a diagnosis made before the traditional criteria for death, cardiac arrest, by any set or subset of criteria would invariably correlate with a diffusely destroyed brain. One of the principal investigators wrote, "While the prognosis for recovery of function is nil and the probability of death within days to weeks is extremely high, one major question remains and perhaps has been brought into focus by the collaborative study. That question is, does a fatal prognosis permit the physician to pronounce death? It is highly doubtful whether such glib euphemisms as 'he's practically dead,' 'he can't survive,' 'he has no chance of recovery anyway,' will ever be acceptable legally or morally as a pronouncement that death has occurred. So brain death is not a diagnosis, but rather a prognosis of death." And as you know, we have accepted that definition that death has occurred. But because of continuing controversy, a presidential commission was assigned to study this, and they decided that brain death was death first because they thought in 1981 the brain was the master integrator, without which biological death would very quickly occur, which again, their argument was based on a prognosis of death, not a diagnosis. And the second thing they asserted was the development of technologies such as ventilators to sustain life masked that death had already occurred. They believed that ventilating a corpse would make it look alive. But did the whole authors of Defining Death agree with this? Well, no. Harvard professor of philosophy Daniel Wickler, who wrote Defining Death's 3rd chapter, Understanding the Meaning of Death, told reporter Rachel Aviv from the New Yorker years later, "I was put in a tight spot and I fudged. I knew there was an air of bad faith about it. I made it seem like there are a lot of profound unknowns and went in the direction of fuzziness so that no one could say, 'Hey, your philosopher says this is nonsense.' That's what I thought, but you'd never know it from what I wrote." But despite Dr. Wickler's doubts in 1981, they codified the idea of brain death into the UDDA, which we've all gone over a few times, so I won't belabor. But are brain dead patients dead? Well, no. In 1998, this was disproved by Dr. Alan Schumann, who documented 175 cases of brain dead people who lived after the declaration of their death under the UDDA, and the TK case that you've seen alluded to lived for more than 20 years. And these people were all dead enough to have been considered for organ donation, but were kept alive for various reasons. And Dr. Schumann points out there could have been more, except for the fact that brain death is very quickly a self-fulfilling prophecy. You either become an organ donor or you have your life support withdrawn in most cases. So again, these cases show that brain death is a prognosis of death, not a diagnosis of death itself. And Schumann's 175 brain dead people continue to show integrated functioning of their bodies. And you can see the great list of things they do. These metabolic activities are the foundations of life, a two-way communication with the environment, and the work of staying alive. All of these are the work of the patient. Machinery does not do any of these things. And does the ventilator mask death? Well, no. Life and death are mutually exclusive. Machinery can only sustain life, not produce it. And I ask doctors and nurses when I talk, would your gross anatomy cadaver look alive if you attached it to a ventilator? The idea is ridiculous. Of course, they would not. People on a ventilator look alive because they are alive. Now, here's a pot shot. This discussion about life support was brought up in this paper published in Chest, which you have in your syllabus. And what the authors say, what we are arguing is that at a certain point of dependence on artificial means of treatment, the organism becomes a non-organismal, medically supported biological entity and can be determined to be dead. So let's pick this apart. At a certain point. Now that's kind of vague and arbitrary. It's based on who gets to decide. Dependence on artificial means of treatment. This is defining disability as death. A lot of people are on artificial means of treatment, people with pacemakers, people on dialysis, people who take insulin. Dependency and disability do not make people as good as dead. And non-organismal, medically supported biological entity is dehumanizing language. This is sort of like referring to the unborn child as a clump of cells. This dehumanizing language is often used to remove people's human rights. So this sentence, and I don't take this as what the authors were maybe thinking about when they wrote it, but this sentence is an arbitrary standard for removing human rights based on disability. So back to Dr. Schumann, based on his evidence that people were living after a brain death diagnosis, another presidential council was convened. They noted that Dr. Schumann's work left two options. Either we have to abandon the neurological criteria for determining death, or we have to develop a new rationale for explaining why neurological criteria should equal death. And despite which seems the more complicated of the two options, you know which ones they chose. Chris, would you hand me one of those water bottles, please? So they made a new rationale, thank you, a new rationale based on a questionable philosophy rather than upon biology. They coined a new term, total brain failure, and said an organism is no longer alive when it ceases to perform the fundamental vital work of a living organism, the work of self-preservation, achieved through the organism's need-driven commerce with the surrounding world. This is an ability-based definition. Now, our conference is being sponsored by the Pellegrino Center, so I found it interesting that their founding director, who was the chairman of the 2008 President's Council, disagreed with the concept of brain death. He wrote in his dissenting opinion, the only indisputable signs of death are those we have known since antiquity, that is to say, loss of sentience, heartbeat and breathing, mottling and coldness of skin, muscular rigidity, and eventual putrefaction as the result of generalized autolysis of body cells. I have chosen to give priority to the welfare of the patient before he or she becomes a donor on grounds that harm must not be done, even if good comes from it. No person should be sacrificed as a means for the good of another. This is a moral precept that recognizes the intrinsic worth of every human being. And in fact, the 2008 President's Council failed to accurately reflect scientific facts. Total brain failure is inaccurate. People, as we have been hearing, with a diagnosis of brain death still have certain brain functions. 20% of those tested, and of course now not many are tested because that requirement has been withdrawn, still have electrical activity. 50 to 84% still have a functioning hypothalamus, and you've heard why that's important, so I won't go over that again. They have metabolism, wound healing, fighting off infections, and as an anesthesiologist, I can tell you they still have the stress response to the incision to remove organs the same as anyone else. And all of these are the work of self-preservation. Now remember, the UDDA legal definition is the irreversible cessation of all functions of the entire brain. brain death diagnosed according to the AAN guideline does not follow the law under the UDDA. And in fact, no AAN brain death guideline has ever been based on the irreversible cessation of all functions of the entire brain. As we've been hearing since the first AAN guideline in 1995, brain death has been based on the same bedside clinical triad of coma, loss of brainstem reflexes, and no breathing with the apnea test. No guideline checks all functions of the entire brain. And here's the most recent one. Again, the guideline emphasized that this is a bedside diagnosis, and ancillary testing is required only if the clinical assessment cannot be safely or fully completed. So let's kind of go through these 4 columns. The test is for unresponsiveness because we have no test for inward awareness. We can only tell if the patient is able and willing to respond. And people can be inwardly aware and just unable to respond, as in cognitive motor dissociation. Second, there can be no cerebrally mediated motor response to noxious stimulus. But the guideline goes on to say, quote, it can sometimes be challenging to determine whether a movement is cerebrally or spinally mediated based solely on clinical examinations. And it goes on to say, if you're not sure if your moving patient is dead or not, you should ask a friend. Honestly, they say ask a colleague, and good luck to you, right? The neurologic exam you can see there, it's obviously not all functions of the entire brain. It's a handful of brainstem reflexes. And then the apnea test is written down, and they give parameters for it. But according to the guideline, and I quote, selection of targets for this challenge is arbitrary because no scientific data demonstrates specific PaCO2 above which medullary chemoreceptors would prompt respiration if they were functional. Now, Dr. Roberts is going to address us tomorrow about whether or not informed consent is necessary for the apnea test. Do you think it would be important to tell your patient's family that the apnea test, according to the AAN, is an arbitrary test with no scientific data to back it up? And the 2023 AAN guidelines do not require ancillary testing except when brain death determination at bedside cannot be completed. And here's the quote, all ancillary tests have shortcomings and none are 100% sensitive or specific. Now this is completely illogical. If the bedside exam can't be done, now the brain death diagnosis completely hinges on tests that the AAN knows are not 100% specific, meaning there will be false positives. Dr. Brahini brought up the new article in the Linacre Quarterly, and I'm going to just give you a couple slides on it. It's an excellent article. In 2007, after a severe traumatic brain injury, Zach Dunlap was declared dead according to the AAN guidelines, but he was a difficult case. He had a skull fracture, and so they couldn't shoot the ice water in his ears because he had spinal fluid coming out of his ears, and they couldn't do his apnea test because of his low heart rate. So Zach's brain death diagnosis was based on brain blood flow scans, which were read as no flow. Later, nuclear medicine experts were divided, with 2 out of 3 questioning, was it low flow or was it no flow? It was a difficult scan to read. Well, thankfully, during preparations for organ donation, Zach's cousin came and gave him a painful stimulus, and he reacted with a purposeful movement. So the organ harvesting was called off. Zach made a full recovery. He holds a job. He got married. He has a little girl. He leads a normal life. But during a TV interview in March of 2008, Zach reported while he was in a coma, he overheard his doctors and his parents discussing his death, and he felt angry about it, but he was unable to move or speak or sign that he was alive. He is a case of cognitive motor dissociation. So the lessons from Zach's case, again, if elements of the clinical exam cannot be performed, the diagnosis of brain death hinges on ancillary tests that are known to yield false positive results, okay? It's absolutely insane that an ancillary test without a specificity of 100% is recommended to establish a diagnosis of brain death in patients who can't undergo the brain death exam. And the fact that Zach overheard his doctors and parents discussing his death while comatose, this shows us the gravity of a false positive declaration of death, especially as many anesthesiologists, unlike what I was told to do, many do not use consciousness blocking drugs. You can look at articles in the literature that advocate doing these with paralyzing drugs and drugs to manipulate the blood pressure. Can you imagine the agony Zach would have undergone in that instance if his cousin hadn't checked his purposeful movement? And that brings us to Jahai McMath. Jahai McMath was declared brain dead in California in 2013 after bleeding complications from her tonsillectomy and palate repair. She was unquestionably diagnosed brain death correctly according to the guidelines of her time. She also would have been declared brain dead with the new guideline. She had 3 doctors who did a brain death exam and declared her brain dead. She failed 3 apnea tests. She had 4 flatline EEGs. She had 1 no-flow cerebral perfusion scan. But after, with the help of Dr. Paul Byrne, who we're grateful to be with us here today, she was moved to New Jersey, the only state with a religious exemption to a brain death diagnosis. And she improved to the point that 2 neurologists, Dr. Calixto Mercado and Dr. Alan Schumann, testified she was no longer brain dead, but in a minimally conscious state. In fact, she improved to the point of being able to follow commands. And she would respond appropriately when asked, Jahai, which is the FU finger? I mean, this child was in no way dead. She is a documented case of recovery after a correct diagnosis of brain death. Now, actual death is an irreversible state. Jahai McMath's recovery shows that brain death is not death as we currently diagnose it with the guidelines. Now, how could Jahai McMath fulfill the requirements for brain death and yet improve? It's very likely due to a phenomenon called global ischemic penumbra, which was first described in 1999 by Dr. Cicero Coimbra. Dr. Nguyen's paper in your syllabus also has a very nice description of this if you'd like to read more. So during periods of low blood flow, the brain shuts down its functions to reduce its metabolic requirements like any other organ in the body. At about a 50% reduction in blood flow, the EEG becomes flatlined and the brain becomes unresponsive to testing. But tissue necrosis doesn't begin until brain blood flow is reduced below 20% of normal for several hours. So between 20% and 50%, there's not enough blood flow to support function, but there is enough flow to maintain tissue viability. So GIP perfectly mimics brain death, but it's potentially reversible if you treat it. I mean, GIP is very similar to a power outage in your home. Nothing works, but the wiring isn't destroyed. So similarly, there is the possibility that with continued treatment to restore brain blood flow, functional recovery, even if limited, could return for some of these patients as well. Dr. Schumann wrote, GIP is not a hypothesis, but a mathematical necessity. The clinically relevant question is therefore not whether GIP occurs, but how long it might last. If in some patients it could last more than a few hours, then it would be a supreme mimicker of brain death by bedside clinical examination. Yet the non-function, or at least some of it, would be in principle reversible. There's been many lawsuits because lay people question whether brain dead people are actually dead. In the case of Aiden Halou, the Nevada Supreme Court ruled unanimously that the AAN brain death guideline does not meet the legal definition of brain death. And because of the increasing number of lawsuits, a group calling themselves, I love this, the Brain Death Stakeholders, proposed changing U.S. law, and rather than encouraging doctors to follow the law, their aim was to make the law align with the AAN guideline. But as you heard, after several years of study and debate, the ULC could not achieve consensus and tabled its work. But just 3 weeks later, the American Academy of Neurology released a new brain death guideline, essentially recapitulating the proposals refused by the Uniform Law Commission. And this is the one that you've heard explicitly allows people with ongoing partial brain function to be declared brain dead. Now, did the AAN have new studies, new facts, or data to support this guideline? Well, let's look at their methods section. A panel of experts from multiple medical societies developed these. Now, it goes without saying they did not invite experts like Dr. Schumann, who might have disagreed. And look at this. Because of the lack of high-quality evidence on the subject, a novel evidence-informed formal consensus process was used. Now, we have been declaring people brain dead for nearly 60 years. Wouldn't you think that there would be some high-quality evidence for it by now? I mean, basically, this echo chamber of experts determined the guidelines by 3 rounds of anonymous voting. The National Catholic Bioethics Center considers the new guideline a decisive breakdown in the public consensus on death and organ donation because it allows people to be declared brain dead in the presence of ongoing partial brain function. But this is not a change. The AAN guidelines have always allowed brain death to be declared in the presence of hypothalamic functioning. Even the 1995 guidelines specifically mentions that brain death may be declared despite normal blood pressure and urine output, both of which are evidence of ongoing hypothalamic function, which is really the same thing as saying, according to the new guideline, that clinicians may declare patients brain dead despite evidence of neuroendocrine function. So this paper proposes a middle-of-the-road position. Given the current state of medical science, we would argue that reasonable certainty can be achieved now by adding testing for diabetes insipidus to the current clinical triad of lack of conscious responsiveness, apnea, and absent brainstem reflexes. One problem. Jahai McMath had diabetes insipidus, which her doctors charted suggests hypothalamic death. So during GIP, there may also be a lack of hypothalamic function. So those who advocate for adding tests of hypothalamic function to the guideline would have declared Jahai dead, even though subsequent events proved that she was alive. So the Emperor Brain Death has no clothes, and the fig leaf of the hypothalamus will not cover him. Jahai McMath proves that people declared dead under the guidelines, with or without tests of hypothalamic function, are neither biologically nor legally dead under the UDDA. So what is driving this diagnosis of death? Well, it's organs. This is Dr. Elko Vidics, and he's an author of the 1995, 2010, and 2023 AAN guidelines, so I think he should know. He said in 2006, the diagnosis of brain death is driven by whether there is a transplantation program or whether there are transplantation surgeons. I do not think brain death examination now in practice would have much, if any, meaning if it were not for the sake of transplantation. Brain death concept does not reflect the reality of the phenomenon of death, and therefore, any guideline for brain death determination will have no basis in scientific fact, and no amount of additional testing can render the indefensible brain death concept defensible. So in summary, I agree with Drs. Verheij, Rady, and McGregor. Heart beating or non-heart beating organ procurement from patients with impaired consciousness is de facto a concealed practice of physician-assisted death and therefore violates both criminal law and the central tenet of medicine not to harm patients. How can we call a person without a brain human and yet deny humanity to someone with brain failure? Brain death is a prognosis of death, not death itself, and harvesting organs from brain-dead donors is an act of homicide against vulnerable neurologically disabled people. Human life continues as long as the body-soul unity continues, even with the help of technology. And the brain death guidelines are unable to predict irreversibility. Jahai McMath met all medical criteria for brain death, including lack of hypothalamic function because she had diabetes insipidus. Yet she demonstrated improvement in brain function to the point of following commands. And this is the one that really burns me. The public is being denied truly informed consent when they sign a donor card. The public at large, when I speak to them, they still believe they will be biologically dead at the time that their organs are taken. They are not told they will still have a beating heart, wound healing, fighting off infections. They're not told that the brain death diagnosis is now philosophical, not biological. I mean, they're not being given the information they need to make what might be the biggest medical decision of their lives. And this really disappointed me. So in this paper, they say, conversely, were all families to be made fully aware and truly informed, one would find very large numbers of people objecting, and that would create needless conflict and chaos. It is the responsibility of Christians to defend the vulnerable, even if it would cause conflict and chaos. Secular voices are being more honest about this. This is Miller and Truax, who have been saying for years, brain-dead donors remain alive, and donors declared dead according to circulatory respiratory criteria are not known to be dead at the time their organs are procured. Professor Thaddeus Pope gave this lecture at Tulane last year. Dead donor rule violations are rampant. What are his examples? Brain death, DCD, and NRP. And utilitarian philosopher Dr. Peter Singer says, I argue that the evidence now clearly shows that brain death is not equivalent to the death of the human organism. In fact, Dr. Singer calls brain death an ethical choice masquerading as a medical fact. But all three of these men, whereas they're advocating for the facts, unfortunately, their solution to this problem is to remove the dead donor rule and expressly allow organ harvesting from living disabled people, which is something we cannot condone as Christians. So brain dead people are still alive and must be treated with humanity and dignity. We must expose the lie of brain death to the public, and we must advocate for living donation. I honestly think if we were honest with the public, I think we'd have more organ donations, not less. A lot of people turn down offers of an organ from family and friends because they think they can get an organ from a dead person. I know a man personally like this who turned down multiple offers. And then when he found out later, after he'd received his organ, when he found out the facts, he felt his conscience had been violated, and he had participated in some way in that homicide of that person who was not dead at the time of the removal of their organ. So this is wrong, and it needs pastoral care. And we must support ethical solutions for people with organ failure. In the meantime, I recommend no one be a registered organ donor. We should not participate in this unethical system. I think you should remove your consent from your driver's license, your healthcare power of attorney, and your electronic medical record. And I'll let Dr. Pellegrino have the last word. We do not know with certainty the borderline between life and death, and a definition cannot substitute for knowledge. Moreover, we have sufficient grounds for suspecting the artificially supported condition of the comatose patient may still be one of life, however reduced. That is to say, for doubting that, even with brain function gone, he is completely dead. In this state of marginal ignorance and doubt, the only course to take is to lean over backward toward the side of possible life. Thank you.